Next up is Mike Wilson, a partner at Mercer Health and Benefits. He has over 30 years experience in the employee benefits field and has extensive experience with both large public and private sector employers. So thank you very much.
Good morning. I feel better about myself now. I've got 2 kids, and they're both married, employed, and out of the house. So what that's worth. Okay, I'm going to provide some perspective relative to the employer-sponsored landscape. And to do that, I'm going to be relying on some data from a recently released Mercer survey. It's the largest survey of its type, with over 2,500 employers that responded to it. And the statistical methodology actually makes it transferable to the entire U.S. Employed workforce. There's hundreds of data points within this survey, and I'm going to be doing the sort of the speed dating version of this and move through the key points here. We've probably all seen an illustration like this in the past. It's an illustration that shows employer-sponsored healthcare cost increases over time, so essentially the last decade. And it shows it in 2 forms. The top dark blue line represents the cost before employers take action. The light blue line below it represents after action, and that action is a combination of not just cost shifting through plan design changes, but most of it actually comes from enrollment redistribution as employees shift between plan types that the employer offers. And then the bottom 2 lines represent general CPI change and wage change. And so what you see here, a couple takeaways are really tremendous consistency in healthcare cost increases over the last decade. And for those like me that have been around in this business for a long period of time, there was a long period when 5 years up, huge numbers, 5 years down. You had that insurance underwriting cycle, and that's disappeared for the last decade. But the bad news is that even with some aggressive action from employers, that the net result is still 2 times wage and inflation growth. So healthcare costs are a bigger portion of their business and a bigger portion of our GDP each year. You hear stories about, and it gets in the news, about organizations that are facing large double-digit increases, et cetera. So that's inconsistent, of course, with the slide I showed before, but it's true. So this shows, using cohort data from the survey, it shows the portion that receive sort of sizable increases. So a quarter of the employers out there around the country had healthcare costs, even after taking action, in excess of a 10% growth from the prior year. A quarter also had no change, and then the other half had something in between. So from a employer to an employer standpoint, it really is quite cyclical. When you translate it to dollars here, and we're showing it this for what I'll call small and medium-sized employers on this particular illustration, it shows the annual healthcare expenditure per covered individual, and that's per covered employee. So you have more dependents, cost goes up. You have less dependents, cost goes down, et cetera. And you can see the number now is hovering in that $11,000 to $12,000 range a year, so $1,000 a month are what employers are spending on healthcare in general. Some spending vastly less, and some spending vastly more. Some of the biggest factors that drive sort of the differential, and if you look at this here, I'll start over on the far right side where you see the 2 yellow bars. That's for those that are local here in Southern California. That's the Southern California numbers for small and larger employers. You can see they mimic the national numbers almost exactly. National numbers over on the far left side. So again, about $12,000 per year, so very little differences in Southern California compared to the rest of the nation. But what you see here is the primary factors that really drive a difference. And the number 1 factor, which was discussed during the prior discussion, is age. Not a shocker. The older you are, the more health expenditures you have. If you put it into actuarial perspectives, it's each 1 year translates to 2 to 4% compounded increase in healthcare cost. So the difference between an organization that has an average age of 40 and an organization that has an average age of 50 is 1.03 to the 10th power in their expenditures on healthcare costs, so huge differentials. And you talk about tech firms. I work with 2 Fortune 100 tech firms. Tech firms used to be young. They're not young anymore. And we see now very common scenarios where employers have the average age of their population at 50 or older. When I started in this business, it was in the mid-30s for most organizations, and currently nationally averages around 45. Additionally, if you have more people covered per employees, so if you have larger families, you're covering your spouse, et cetera, of course, the cost is larger for that employee. So you can see how that drives up cost. And then when you have large proportion of your employee population that are labor groups, you have particularly high cost because you have a combination now of generally richer designs, usually older populations, and more family members that come along with it. Now, one of the things that came, and it's sort of a relatively recent trend, it's accelerated quite a bit and is somewhat related to ACA, is a drive from an employer standpoint to shift the burden from one employer to the next. Because why would you want to cover the dependents of a working spouse when the other employer can cover the dependents of a working spouse? So this illustrates 2 primary strategies that employers have embraced around that, and kind of the acceleration around that just in the last 2 years. One is, don't even allow the spouse, if they work, to be eligible to participate under your plan. UPS got a lot of sort of notoriety for that heading into 2014, but now that translates to about 10% of employers, so quite a few that have employed that strategy. And secondarily, just providing an additional surcharge, because you charge a surcharge, and that surcharge exceeds what the payroll deduction they would pay under their primary employer, it incents them to elect coverage under their primary employer. In ACA, the affordability provisions, the pieces of the Accountable Care Act that said we have to provide affordable coverage, it only applied to the employee, not the dependents. Charge whatever you want for dependents, but there were caps on what you could charge for the employees that shifted the mindset of employers to strategies that moved the dependents to alternative plans. Okay, a lot of people think that the larger you are, the cheaper the healthcare cost will be because you've got purchasing clout. This illustrates across the board from small employers, medium-sized employers, all the way over to jumbo employers, and you'll see that that is not the case. In almost all situations, employers are purchasing through a third party, usually an insurance company. They're getting the discounts from that insurance company that apply to all of their the insurance company's plan members. So if you're a 50 life group or you're CalPERS and you're using Anthem, the amount that the provider is receiving is generally the same. When you get to the very far end of the spectrum for super jumbo employers, you do see the costs go down a bit. It's driven by the industries associated with 20,000 or more employees. You shift a lot more to service-related industries that have very sizable employee populations, and now you get younger populations and less rich benefit programs. If you look at HMOs, and we're going to talk a bit about that for those that are from Southern California, and I am, here, we're showing the spike in costs on HMO plans for the last 7 or so years here, and then showing Southern California over on the far right side of the screen. And what you see here is a huge increase in costs in 2016 across the board from a national standpoint, and you see that the costs are a little bit lower than those national averages that I was talking about a moment ago. When you look at PPO costs, the chart starts to look a little different here. The scale is actually lower, so the growth in PPO costs has been a lower growth line than HMO costs nationally. The key operative term there is nationally. But if you look at Southern California, where we're from, particularly here in Orange County, over on the far right side of the screen, you can see that fee-for-service costs are considerably higher than national averages and considerably higher than the HMO numbers that you saw on the prior page. We're going to show you the sort of the enrollment implications of that in a minute. It comes down to capitation, shifting the responsibility of the financial burden to the provider community. It's extremely effective. If you talk to actuaries around the value of capitation relative to healthcare costs, they'll throw out numbers between 20 and 30% impact on healthcare costs simply by shifting to a capitated delivery model. Now here we're showing PPO national side by side to Southern California. You can see the huge 20% higher PPO costs in Southern California than national, and you can see when you look at the HMO side, it's inverted the other way. And then on the far side of the screen, we're showing HSA, high deductible plans that are eligible for HSA accounts. So predominantly you have to have a high deductible and you can't have first dollar benefits, particularly around prescription drugs, to be eligible for an HSA plan. And then on the far side, HSA is for employers here in Southern California that offer them. The takeaway here is that nationally, HMOs cost more than PPOs. In Southern California, it's inverted in a big way. And remember, Southern California is in the national numbers. So it's really impacting those HMO numbers in a large way. Pharmacy costs have spiked. There's several reasons for this from an employer standpoint. A combination of generic utilization essentially peaking at a level. So we had optimization, for a decade. Generic utilization went up. That really had a direct impact on pharmacy costs. So higher generic costs, lower sort of ability to optimize generics at this point because the replacement ratios are unbelievably high for generics, and specialty drug costs, which I'm sure you're all aware of, sort of spiraling out of control, have led to an increased spike there. The specialty drug cost increases alone translate to 25%, 1/4 of the increase for the total healthcare bucket for employers from one year to the next. So just that one category is a large portion of the cost increase. Okay, so what does this mean? It means that HMOs are dead in most of the country. So what we're showing here, if you look from the bottom up, is it shows the distribution of the actual enrollment for the total US population for people through employer-sponsored plans, public sector, private sector, labor trust plans, all of them together. And you can see that we had 70% PPO penetration, 20% there. We had a fast growth of account-based consumer high deductible plans. It's the blue bar on the very far right. A few years ago, the HSA-based account plans passed HMOs, and you can see now they're twice that. There's 2 times the amount of enrollment in the United States in a account-based HSA or HSA-eligible consumer-directed plan than is in an HMO. However, look at the top. That's us here in Southern California. You can see there it's a completely different story, and we show it for small employers where over 70% are in a HMO environment. And for large employers, and the large number is skewed a bit because the large employers are employers that are headquartered here, and they have many employees outside of Southern California, and so that skews those numbers a bit as well. But it tells you that it's 60%, it's 70%, it's some number like that of the employees that live in Southern California that are within an HMO environment, driven by the price differentials that I showed on the prior page. Money talks with the employer-sponsored world, and as you got a client that's headquartered in Texas, no HMOs, well, there's a couple but essentially no HMOs in Texas. 100% high deductible plans for their population. Work with local organizations that are struggling because they've got almost everyone within an HMO, and they're struggling with providing affordable choice or options outside of the HMO world. Now this shows, and here's the sort of the dilemma here. Because what this is showing is it's showing in a PPO, not a high deductible world, a PPO world, which could be a high deductible. It shows how in the last 7-8 years, the cost shifting has been shifted to the plan member through higher deductibles, cost sharing, co-pays, out-of-pocket maximums, et cetera. And this is just showing the deductible piece, a very steep line. The small employer average deductible is almost $2,000. And that's not even in a high deductible HSA plan. That's in the PPO plan around the country. And for larger employers now it exceeds $800 and is growing at a fairly quick pace, as you can see there. Now, if you take into consideration the fact that employees also pay a share of the coverage through payroll deductions, this illustrates here, this is blended average across all industries, what portion is borne by the employer and what portion is borne by the employee. You can see that the number is between 25 and 30% is borne by the employee. But that's 25 or 30% of what the plan pays, not considering the fact that the individual also pays the deductibles, cost shares, and so on. So if you think in terms of the PPOs that I was sharing there, having an actuarial value of, we'll call it 75%. What does that mean? It means that for the average person utilizing the plan, 3/4 of the expense is picked up by the plan, 25% of the cost is picked up by the employee through cost sharing. You add on the fact that they're also paying upwards of 30% of the cost of the 70 or 75%. And when you put those things together and you do it by industry or you do it by employer, you see that the average individual is picking up 40 to 45% of the healthcare cost. That number has changed radically in the last decade. It was closer to 25% in totality 10 years ago. It's now 45%. That translates to very significant cost shifting. It's the reason why on that first financial exhibit, there's a gap between those two lines. The line that said healthcare costs are going up at X, but the real cost for employers are going up by Y, because the majority of the success they've had have been through the form of cost shifting to individuals. Now, this shows sort of the challenge relative to sort of consumerism, but it actually applies to PPO plans as well, because only a small portion of healthcare is subject to consumeristic sort of marketplace factors, and most of it is out of the control of the individual. So we'll equate that to roughly 30%. Additionally, data is showing that high deductible plans are resulting in less care for the individual. So the cost shifting has now translated to a care issue, and then the real additional sort of challenge is employers have played their cards. They've played their cards. They've done what they can to modify the plans to a point where employees are paying 40, 45% of the total cost, as I said. So are there more cards to play, at least out of that deck? One of the things that's been a recent, of course, trend is the development and growth of ACOs. I saw, Vivity sitting outside, and all the major health plans have ACOs, and some of the local health systems have direct ACO sort of options as well. This shows the adoption rate of ACOs and the degree that they're doing it in what sort of form. On the left side, it shows that depending on whether you're a jumbo, super jumbo, 20,000 or more employees, so in this market in Orange County, what do we got, 3 of those? And then just all large employers, the percent of employers that have an ACO in place today that uses an incentive structure. The incentive structure could be through the design multi-tier network, so you get richer benefits if you go to the ACO as one structure, or it could be that you actually have a separate plan that has a lower payroll deduction and you theoretically incent that way. But it's a relatively small number. A much larger number have ACOs that are just embedded, they're hidden within their existing structure or networks. Anthem has their enhanced personal health care network. If you're in the PPO within Anthem, you'll never know if there's an ACO. The ACO is embedded within their traditional PPO. And what's happened is now, it's been an interesting challenge for employers, because employers are being asked to pay for services that don't happen. Up until now, they pay for services that do happen. You can see the claim has an expense. You add all those up, you see what the expense is, and you decide if you have to kind of increase rates or not. But within the ACO world, there are incentives and structures that sort of move the pendulum in another way and actually force us to start thinking about quality, which is obviously a good thing as well. Virtual care, a very, very large spike in what I'll call availability on virtual care. This shows just in the last 4 years, using telemedicine as an example, the very, very quick rise of availability of telemedicine here, and you can see that it's grown just astronomically in a short period of time. The bad news is that utilization tends to be extremely low, extremely low. If you look at it relative to the tens of thousands of visits that happen at a typical employer, it's a fraction of the care that's provided through virtual care at this point, but definitely a quick growing trend. Now, for a few employers in this market and for more employers outside of this market, particularly for larger employers, there's a desire of exploring, can we take the care on site? This shows on-site or near-site sort of clinic growth within the last 4-year period of time. You can see the trend is going up. I would say that this is a far more prevalent practice, again, outside of Southern California. I have a few local-based organizations. I have one who does it locally here, and I've got a number that have looked at it. The challenge in this market has been in a capitated delivery environment. If you bring care on site and you create a clinic on site, frequently you're paying twice. You're paying for the capitation if the person goes to that or not. You're paying for the care on site. So it's been a real roadblock relative to on-site care development in this market. And then out of the kind of a blast from the past, there's been a bit of a surge in employers adopting secondary expert medical opinion. It's been around a long time for those that know organizations like Best Doctors or so on, and now you've got a whole slew of organizations in this space, but this has also been a recent trend to provide people that have catastrophic issues the ability to obtain sort of third-party opinions, particularly if you're in a managed care sort of organization. And then the final sort of trend I'll hit on, because it got a lot of press a couple of years ago, is on private exchanges. Private exchanges are basically employers say that, I'm no longer going to do all of the direct contracting myself and pick my designs, et cetera. I'm going to go into an existing private exchange, not a public exchange, but a private exchange with other like-minded employers. So there's a common administrative platform, common plan designs, some degree of efficiencies, et cetera. And there were some fairly kind of sizable projections of the U.S. having, 40 million of individuals within that market within a 5 or 6 year window of time. You can see it's not quite that number. At this point, it's not insignificant. 5% of employers are within a private exchange model. At Mercer, we have a little over 2 million employees, not counting their dependents, within our private exchange. What we're seeing is the predominance of the growth within the private exchange world has been medium market and smaller employers, not jumbo employers, because as I illustrated much earlier on in the presentation, size does not matter a lot relative to healthcare purchasing clout. So the majority of organizations that have adopted it have been around administrative advantages, not really on the cost of care advantages. So the key takeaways I'd ask you to walk away with are that we've got stable sort of healthcare costs for the last decade, but even after employers doing some pretty aggressive actions, costs are increasing at twice that of general inflation and wage change. High deductible plans, whether in a PPO environment or a true consumer-directed health plan environment, are taking over the world. They are going to pass the PPO number within 3 or 4 years. That number will be the predominant vehicle for providing health care in the United States in a relatively short period of time. We're insulated from that here in Southern California because of capitated delivery and the tremendous efficiency it does. We've got that roughly 30% price gap that I was showing on the difference between HMO costs and non-HMO costs in this market. Employers are desperately seeking options and are very open to unique network strategies, but they've got to have a price point option that is appealing to them. And there's been an exhaustion of the ability to really modify plan designs at this point because there's almost nowhere else to go when you've got a $2,000 deductible within health plans. So with that good news, I'll pass it on to the next speaker.